Hello, everyone. I'm Linda Harmon, Executive Director of Lamaze International. Welcome to Lamaze International's first parent webcast, Getting the Most Out of Your Hospital Tour. This session is just one of the many resources available as part of our Push for Your Baby campaign. We look forward to an interactive and informative session today, and there will be more parent webcasts to follow later this year. Before we begin, I would like to remind attendees that you are automatically muted during the webcast. To submit questions, please use the question box on the lower right portion of your screen. Questions will be answered at the end of the presentation, but feel free to ask your question at any time during the session. You will also be asked to answer several poll questions during today's presentation. Please answer the poll by clicking one of the answer choices that appear on your screen. Now I'd like to introduce our speaker, Allison Walsh. Allison is a Lamaze certified childbirth educator, a board-certified lactation consultant, mother of 3, and manager of the Parent Education and Lactation Services at Beth Israel Hospital in New York City. Allison serves as a Lamaze delegate to the United States Breastfeeding Committee and is a past president of Lamaze International. Welcome, Allison.
Thanks, Linda. First, we're going to do a poll question, I think. So Linda explained how to access the poll, and it's a simple question. Are you pregnant? A few answers here. So take a minute, please, to answer that poll. And I think we're going to get the poll results coming up. And I'm not seeing those poll results, Casey. Is that?
Sure, I'll go ahead and read them to you. So 43% are not yet, but maybe soon.
We have 0% that say yes and they're in their first trimester, 27% are in their second trimester, and 30% are in their third trimester.
Great. Okay, so we have a nice mix of folks. So I'm guessing that some of you may have already gone on your hospital tour, and I still think this would be valuable to you because you can certainly have an opportunity to go back and think about any questions that weren't answered and get that information if you need it. So thanks for joining us again today, everybody. So we're going to talk about the hospital tour, and the first question is, why bother? You have so much to do in late pregnancy, and is this a really important thing to do or not? If we know where the entrance is, do we really have to go and see the whole unit? And I would say yes, I think you absolutely should. We know that women really want to see where they're going to be giving birth to feel safe and secure and comfortable. They want to lay eyes on some of the staff and know what some of the amenities are. And partners often report that they want to avoid the mad scramble. They want to know exactly what door to use and what elevator to use and where to park the car and all that kind of stuff. So getting to a tour helps you to prevent that mad scramble ideally and get some of the story on what labor and birth is like at this particular hospital. So that's very important. And I'm going to tell you 2 things about myself. One is that I do about 90% of the tours here at my hospital, which is a large hospital here in New York City. And so I just did one last night, actually, and I love doing the tours. I personally look at them as an opportunity to educate parents. It's almost like a mini class, and I know that's, tours are different in any, from one hospital to another, but I love when people ask questions. I love when people, I call them shoppers. They're not even pregnant yet, or they're 5 minutes pregnant and they come on a tour. I think that's wonderful, and so I think it'd be great to get the word out to friends and family, anyone that might be pregnant in the future, that this is an important consumer decision. And oftentimes, if you are later on into pregnancy, it may feel harder to make different decisions if you need to. So coming early, I think, is a really, really great thing. The second thing I want to tell you about me is that I remember so vividly the hospital tour I took when I was pregnant with my first baby. And I will share with you that despite the tour guide being wonderful, I cried the whole way home from the tour and said to my husband, I can't have a baby in that hospital. It just seems awful. It was, it looked dank and depressing, and I wasn't sure about what amenities they really offered. I had a lot of questions, and until I went back to my midwife and really asked her the questions, I didn't get the answers that I needed. So that was my own personal experience, and I do carry that with me on every tour that I give to try to make it better for parents. But I share that with you to let you know that if you don't have the most satisfying tour experience, there are other ways to still get this information that I'm going to recommend to you today. So So a lot of hospitals are moving to online tours. That's getting very popular here in New York City. It's hard to organize moving many people through, labor and delivery and maternity units. So from an administration perspective, I completely understand that. But from a mom's perspective, that doesn't really work very well for a lot of women. They want to see and experience and ask questions in person. So again, we're contending that it absolutely is still worth the visit. So at Lamaze, we're thinking about two goals that every parent should keep in mind. Preventing that mad scramble when you go into labor, and we've seen way too many depictions of that in TV and movies, and hairpins flying, suitcases falling open, and everyone's stressed out. So getting the lay of the land hopefully diminishes some of the stress. And again, it's even more important, I think, for the dad or the partner who feels so responsible to bring the mom to the right place. Next, getting the lay of the land about what labor and birth are like in your hospital is really important to get good information and insights that will help you gear up for your big day. And we're going to talk about some specifics. So there's two ways of looking at this here. So we know what parents want, right? Parents want to feel safe and ready. They want to be familiar with the deal, the lay of the land, like I keep saying, and understand what's open to them and available. While hospitals want patients to know what's going on, what to expect, where to go, how to do things easily, have their paperwork, in order, to know what is done in this hospital and what is not done in this hospital. I'm somebody that still feels like you should ask for whatever you want and advocate for that, and if there's no medical reason to prevent you, you should get to do it, and that's how we do things around here. But, from the hospital's perspective, these tours are done from the staff's perspective to make everything easier when this family comes in to have their baby. The other side of that, too, is that patient satisfaction is hugely important in hospitals today. So there is a very big customer service bend to a lot of tours nowadays. Okay, so preventing the scramble. It should seem pretty simple, but when the big day comes, things can be very overwhelming and stressful when you're dealing with contractions, or not. Some people are perfectly calm as well. But the more simple facts you get ahead of time, the easier it'll be to get yourself to the right place when labor kicks in. So during the tour, ideally you want to become familiar with where to go. Most tour guides cover this, but if not, you could ask specifically about parking options, which entrance to use. Often that depends on the time of day. Many hospital entrances close after, whatever, 9 or 10 at night, and then there's only one entrance that's open all night long, so definitely ask those questions. Sometimes it's good to put that in writing, have that in writing so you can hand it to a partner or whoever's bringing you in. And if a problem happens during pregnancy and you need to come in for a scheduled induction or cesarean, ask this information again just to make sure that it's true that you're going to the same location that you're initially told. So when things start happening with labor, you suspect labor is starting, who do you call? Of course, your doctor or midwife. Let them know what's going on. They can help you make a decision about when is the right time to come to the hospital. They also can let the staff at the hospital know that you're on your way in. But even before calling them, I would think about calling your doula if you have a doula. They are really wonderful at helping you to decide when it's a good time to come into the hospital. Nobody wants to come in too early and be sent home. That's a question I get all the time. People are so worried about coming in early and not being in enough labor to be here and getting sent home. They feel like they'll be embarrassed, or they feel like it'll be depressing if they really thought it was the big moment and it's not. I definitely want to assure you that that happens all the time, and it's not only first moms, it's moms that have had many babies sometimes that we say, you know what, come back later. So doulas are wonderful at helping you to decide when you really need to come in. So also what to bring with you, and we're not going to spend time on this webinar getting into how to pack a bag to come into the hospital, but definitely know ahead of time about what paperwork you need. If any, most hospitals have gone to online registration systems now, it seems, but definitely check with yours if there's anything you need to bring with you in terms of filled out paperwork. Marriage certificates for a birth certificate are required sometimes in some situations, some locations. So this is all important to ask on a tour. So the tour. Here's a poll question for you. What kind of labor and birth do you envision at your hospital of choice? So we have two answers here. Do you think it's going to be a high likelihood of induction, epidural monitoring, or cesarean? Do you think there will be a lot of great support with doulas, midwives, birth balls, tubs, and jacuzzis, more of a normal, natural approach to birth? So, Casey, I know you'll let me know when we have those results in.
Sure, I'm just going to let a couple more people get their votes in as they're trickling in here.
Okay. So this is going to help us to start to identify what is most typical, and typical is a word we're going to really hone in on here.
So we have 22% of people envision likelihood of induction, epidural monitoring, or cesarean, and 78% of people envision supporting environment.
Great. Okay, good. That's great. Okay. So let's dig into what really matters here and learn about the care that's provided in your hospital. So at the same time, like I said before, there's a tiny bit of a conflict here with a hospital tour because the hospital, of course, wants to put their very best foot forward. Remember, it all ties back to customer service and patient satisfaction. So here we go. I love this graphic. What's available and what's typical, and I alluded to that a minute ago. Available can mean, yeah, we have that. We have a tub. We have this. We have that. But what's typical? Is the tub something that women use a lot in labor, or is it something all the nurses are comfortable using, or not? So there was a hospital near to me that put in a beautiful tub, and it never got used, not once, because there wasn't protocol written around how to use it. The nurses weren't comfortable. They were worried about infection control and yada, yada, yada. So even though it may, I don't even know if it was advertised. It may or may not have been. But if it was advertised as, hey, we have a jacuzzi tub on labor and delivery, that's great, but what's the reality? Were people using it? And the answer in this example was no, they really weren't using it. So always ask these really specific questions about what is available, but how often is it being used? So another good one to think about is birth balls. And hopefully you've taken a wonderful Lamaze class and you've gotten to use a birth ball. If not, you may have seen one at your gym. It's a very big physio ball that I think we stole from the physical therapists of the world that we use for birth. They're wonderful for positioning and comfort and progress in labor. And, you know, if you say to your tour guide, oh, are birth balls used in this hospital? And she says, oh, yeah, you can if you want to. That may be an answer that says, yeah, no one really does that. But a really better question might be, do you have them here for me to use? And if they're in every room and in plain sight, chances are staff are comfortable helping you to use them. So it's going to tell you a little bit more than if you just say, can I use a birth ball in labor? There's a big difference between what's possible and what's typical. And, you know, ideally, we don't want to have to work so hard to negotiate something that should be simple. So a hospital tour is a great way to get a sense of what most moms typically experience, and this is going to be able to help you navigate your options. Again, typical is the real key word here. Okay, so some key issues we have to explore. We're going to spend some time digging into all these. So we're going to look at numbers, you know, rates of different things, language that's used on the tour, communication with staff and healthcare providers, what comfort measures are available, what labor support is available, and then getting into some of those policies and procedures around labor, birth, and postpartum. So, oops, I'm sorry, I think I've gone out of order here in my, nope, okay. So the numbers. I've gone back and forth on this in a little bit in my mind. I think the numbers of your hospital are important to know. People always ask me on the tour, what's your rate of cesarean, or what's your epidural rate? And I'm always happy to provide that information. And here in New York State, we have to provide that information by law, which I love. I'm happy to provide that information, and I do. And then I say to the mom, it is more important, in my opinion, that you talk to your own doctor or midwife and ask what their rate of whatever, cesarean, epidural, episiotomy, whatever's important to that mother, is. Because practices that are highly interventive can skew the rate for the institution. So always know that and understand what the context is. some institutions will say, well, we're a very high-risk hospital, and that's why we have so much cesarean here. That may be true, but that may not be true. I love to joke around with my colleagues here and say, well, is this woman really high risk, or is she perceived high risk? Meaning that the mother says, gee, I'm 35, I'm high risk. That's not supported in the medical literature alone to be, something that we should feel that this woman is now high risk because she's over 35, for example. So what is really high risk is important to understand. So if the hospital gives you that story, the tour guide says, oh, we're high risk, that's why we have so much of this or that, that may be true, but I would dig a little deeper for sure. So it's good to, if you're interested, to ask some of these questions about fetal monitoring, IV drips, induction, cesarean, what the rate of VBAC is, vaginal birth after cesarean, if you're interested in that. That's very important. Yeah, so let's talk about language for a second here. Big words, big difference in words. Let and allow are very different than free to choose and have access to. And what body language are you seeing with your tour guide? Does this person look relaxed, or does she look nervous and tense? Does she look like she's, or he is, putting on the public relations hat, or are they being very comfortable with the information they're sharing? And check the source. How knowledgeable is your tour guide? Is this somebody that really knows what's going on? In some hospitals, I understand these tour guides are volunteers working from a script. If that's the case, you might really have to dig deeper to get further information. Ideally, it's somebody that either works on labor and delivery and really is involved in, birth on a day-to-day basis, or is in some other leadership position that they're involved in that, and in policy making, and in, again, customer service and all that. We want to make sure that this person really knows what they're talking about and is not just reading from a script. So who is the decision maker is another important thing. If a cesarean becomes necessary, for example, or say even an induction, whatever kind of intervention it is, doesn't really matter. Women always ask me, well, who is going to make that choice? If I'm in labor for a very, very long time, and when will I have to have a cesarean? And I always explain that here in our hospital and in most places, that's not written in policy, because it has to be a case-by-case decision based on this woman and her body, her health, her baby, how her baby's doing in labor, and how the labor is progressing. So it's not that cut and dry. And I do find that sometimes certain healthcare providers will say, oh, gee, I don't want to do an IV for you, but I have to. It's hospital protocol. Well, that's not always true, and that's a big one that I catch some of our folks in here. That's not our policy. It's really up to that healthcare provider. So find out in your own case who the decision maker is about some of these things, and if you have wiggle room. If it's your own doctor or midwife, it's usually a lot easier to negotiate with them than try to change a hospital policy about something like, like an IV. So listen to how the tour guide is phrasing your options, all right? And again, are you saying you're allowed, or free to choose, and how often things are being done? And those are great questions to ask. When was the last time you saw a mom give birth other than on her back? What if I want to squat to have my baby, or use the hands and knees or side-lying position? How often is that done? Ask really specific questions, not just yes or no answers. Okay, so in terms of communicating preferences, there's a term that we use in hospitals called chain of command. And I love to think about that here for chain of communication, starting with you guys as the patients, as the moms and dads out there that are trying to advocate for your own experience. So on the tour, it's good to understand what the best way is to talk about some of these preferences and if things come up in the labor. So the first line usually is with your nurse or whoever's with you, to start with her if you have specific things that you want during your labor, to communicate that. And because the nurse is usually the one that's spending the bulk of the time with you in most settings. Ideally, you've talked to your doctor or midwife about all the things that are important to you prenatally. I love to tell parents that labor is not the time for a philosophy discussion. It's almost too late at that point. It's never too late, but it's almost, it's just much more difficult at that time. So when you communicate preferences, It's really important to do that prenatally. So a lot of moms take time to do a birth plan, which is a term that tends to get staff's backs up. You know, sometimes nurses that I've trained in here and in lots of other places will say, oh, the woman that comes with that long birth plan, we're going to get the OR ready. She's definitely having a C-section if she has all these wishes for her birth. And that bothers me a little bit, because we know from research that the higher a woman's expectations about her birth experience, the more likely she is to have them. So that's one piece I want you to hear. And the other piece I want you to hear is that you are not wrong for wanting a positive experience. Everybody wants a healthy baby. Everybody wants a healthy mother. Of course, that's the most important, but right up there is having a positive experience. So many women today feel like, well, whatever it takes to get this baby born, I can do it, you know, even if it's awful, it'll be okay. That's not how it should be. And so doing some of this work ahead of time increases your chances of having a good experience, a positive experience, an empowering experience, an earth-shattering, life-changing, amazing, ecstatic experience. That's what, you know, we childbirth educators at Lamaze want you to have. We don't want it to just be okay and I got the baby. We want it to be amazing. And honestly, that's how a lot of us become childbirth educators, because we're so motivated to help women have those experiences. So the term birth plan is a little bit charged, because some staff will say, oh, you can't plan your birth. Well, that's true in some respects. Labor and birth are unpredictable in their nature, for sure. But what you can do is outline your birth preferences. And it's not as catchy to say list of birth preferences as it is to say birth plan, but I like to think about them interchangeably and hopefully disarming some folks in the meantime. So this is a great communication exercise to just plot down what's most important to you. There are online versions of birth plans that are okay to look at, but I don't recommend downloading them and checking boxes like a lot of them want you to do. There's one that I've seen from a popular website that is 12 pages long, and I can assure you that no one's going to read that. So, and also many things that are listed on there are just not commonly done in hospitals here in the U.S., so maybe more applicable to other places, or 30 years ago maybe, but not today. So on one sheet of paper, a little opening paragraph about labor and birth are predictable in their nature, but in an ideal world, these are the things that I would like to have happen at my birth. And then bullet point them, boom, 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 down the line, one page only. And if you're somebody that wants an unmedicated birth, I think the very first bullet point should be, in bold, capitals maybe, please do not offer me pain medication. I will ask for it if I need it. Okay, that's a huge one that women report to me. They came in and they offered me the epidural over and over and over again, and I really didn't want it. Just tell us if that's what you want. We won't keep asking. So that's an important one to know. But anyway, you've talked ideally about your birth preferences with your doctor or midwife prenatally. Bring a copy of this little list in with you to the hospital. It does become part of your chart in most places. And even if it's just sitting on a table, because a lot of charts have moved to electronic methods now, the dad or the partner can make sure that everyone who comes in that room to offer you care, if it's a doctor, a midwife, a nurse, an anesthesiologist, whoever, they take a look at it. Just by gently saying, hey, by the way, we have this little list of preferences over here. If you don't mind taking a quick look just to get to know us a little bit better. I find it can be very disarming that way, but we need to make sure that these preferences are known, which is kind of to the second point here about closing communication gaps during labor. You may have gone through all this with your doctor midwife prenatally, and they may have said, yes, 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 this is wonderful, I love it, of course you can do all this, and of course we won't do all that, whatever you want, unless it's medically necessary. But oftentimes they are not the one that's with you for the bulk of the birth or at all. And you see the box here on this slide from Listening to Mothers Too, which is a national study of women giving birth in the United States a few years back. And I hate the statistic, but I wanted to put it in. For nearly 1 in 3 women, their primary birth attendant was not their prenatal care provider. Instead, it was someone they had met briefly or never met. So, we stand a good chance of not having had time to communicate effectively with somebody before we meet them for birth. A lot of times, doctors will come in at the end of the birth and just do the pushing with the mom. Meanwhile, a lot transpired in that labor, and there are a lot of decisions that may have been made that, we need to make sure there's clear communication on. So who's going to take care of you before your provider arrives, if that's the case? This is a question you really should ask your own healthcare provider about prenatally, and making sure your preferences are known to them. It's going to be different for everybody, and I'm not going to go through all the scenarios, but one scenario to be aware of is if you're in a teaching hospital, some doctors or even midwives may have practice agreements that the resident is going to take care of you until they come at the end when you're pushing, and give report over the phone to your doctor and make decisions that way, looping your doctor in, but they would be providing care to you in their absence. So, it's important to know that you don't have to have medical students or nursing students or anyone observing you or giving you care that you don't want, and that's regardless of your insurance status. So definitely something to talk to your doctor about ahead of time, doctor or midwife about ahead of time. Please remember, too, that there are shift changes for nurses. I like to joke around and say the nurse does get to go eat dinner or have lunch or go home at the end of her shift, even if you haven't had your baby yet. So there may be, you may have more than one nurse. Most moms do have more than one nurse. So it's good to, good to make sure that they know what your preferences are, and hope that they're receptive to your labor and birth preferences. You probably have heard the adage that my grandma always said, you get more bees with honey than with vinegar. So always start from a place of collaboration when you're speaking to staff, not, we don't want this and we'll never have that and whatever, but instead, again, hey, over there is that little list, just we want you to know ideally what we would like to have happen, and if you can help us to have that happen, that's what you're asking for. So on the tour, you can ask questions, too, in terms of staffing and what the day-to-day reality is like, on the labor floor. How many nurses are typically on the floor at a time? And what if you don't connect with this nurse? You don't click with her personality-wise or philosophy-wise? Can you change nurses? And the answer should be absolutely yes, that you can. Go out and talk to the charge nurse or ask who's in charge of the nurses that day and just say, we really want to have this kind of birth, and we're concerned that this nurse isn't going to help us to have that. And certainly, if there's a bigger concern at hand, let them know, what the real issue is, of course. So things to ask too are there privacy curtains in front of the door, so when people come in the room, is her privacy protected? And I already touched on observers and medical students, but definitely letting people know that ahead of time. I have seen wonderful. Some of my nursing colleagues hate this, but I love it. I've seen people bring in wonderful signs on bright fluorescent paper that say something like, essential staff only, no observers or students, please. And they just hang it on the door, and they set their boundary that way. So you can do that, too. All right, so let's switch gears and talk about comfort for a minute. What are you going to have access to that's going to make your labor more comfortable? Now, of course, we hope that you're doing the bulk of your laboring at home before you come into the hospital, so that you're in really nice, booming along, active labor. You've hit your stride. You've found your rhythm and ritual, and ideally that's just going to continue over, once you're in the hospital. So on the tour, ask about what's available to you. So we don't want any surprises if the hospital doesn't have something you were counting on, when you're really in labor. We know that water is incredibly helpful to diminish pain in labor for almost all women. Are there tubs? Are there whirlpools? Are there showers? What's available to you? That we know that can reduce the need for pain relief. But which brings us to pain relief. If you do want medicine to relieve pain in labor, what's going to be available to you there? Is epidural readily available, or are they injectable drugs? And definitely we hope you're going to take a good Lamaze class so that you can learn, the benefits and the side effects of those medicines too. I mentioned birthing balls earlier that can help you to stay upright. And here's a picture of a mom leaning over the birth ball as it's up on the bed. Sometimes moms go on all fours and lean over the birth ball that way, or put it behind their back and stand against a wall and get a nice back massage with it. Birth balls are wonderful. They'll open the pelvis and increase comfort, keep labor going. Does every room have one? Do they only have a few of them? If they only have a few, definitely consider bringing your own. They are really, really inexpensive, and I love to joke around on the tour that if you bring your own in, it's a guaranteed way to have everybody get right out of your way. When they see a pregnant woman walking a little bit funny and the dad carrying a birth ball, it's like a parting of the seas. Okay, everyone gives you the elevator right away. So don't let the air out of that birth ball, leave it blown up, and come on in. So I mentioned epidurals already, I think, yes. So so if the hospital tour guide says that most or all women have an epidural, that is definitely something to think about. What does that mean? Does that mean that everybody in your area is sold on epidural as being the only way to have a baby? Or might it mean that the hospital is encouraging epidurals, or the staff are encouraging epidurals? And you know, both can be the case. You know, both can be the case. So it is a good idea to get that pulse of, you know, what does it look like in your hospital? How many women are having epidurals? You know, in the United States now, it's most. So just to know that. But that doesn't mean that you can't have your labor go on without an epidural. And even in the most conservative hospital, where maybe they're selling epidurals, you know, as you're walking in the door or whatever's going on, I've heard all kinds of crazy stories, you still can have your natural birth, normal birth, whatever you want. It just might mean that you're going to have to advocate some more, you know, and be clear about what your needs are. I love to tell the quick story of a friend who had a baby in a very, very conservative hospital here in New York City. I think their epidural rate is 98%, and the 2% that don't get them are people that walk in and have their baby 10 minutes later. But she really didn't want one, and even though she was with a very conservative doctor in a conservative place, she made her wishes known and was able to have this natural birth. And she said to me, I swear balloons almost fell out of the ceiling with some confetti. The nurses were so excited to see a woman not have an epidural. They were actually really very, very encouraging and thrilled to help her to do something different. So, you know, it can really go either way. You can have unsupportive staff or staff that are thrilled to help you. But it's not a bad idea when you come in labor to say, this is the kind of birth I want. Do you have anybody working today that might be really interested in helping me to do that? There are certainly nurses that love helping women to have normal, natural births. So that's a good one to think about. Okay. So in terms of labor support, you know, we've touched on staff a little bit, but we can touch on it a little bit more. How much one-on-one time can you expect from your nurse? And the answer is probably going to be it depends on how busy a day it is and how many people are working that day and whatever. So definitely, like we said before, go deeper and ask about how many patients one nurse usually is taking care of. When you begin pushing, that nurse is likely not to leave the room, and it would become one-to-one patient, you know, nurse ratio at that point when pushing begins. But what's going on before that, you know? Are doulas welcome? I think hopefully everybody on the call knows what a doula is, but doulas are professional labor support people. They are trained to facilitate progress and comfort in labor. They're not medical folks. They may be a nurse or a midwife or something else in another part of their life, but when they're in the doula role, they are there to provide labor support. So hopefully the hospital is welcoming of doulas. I know that we are, and there's so much research on how effective doulas can be in terms of lowering intervention rates, increasing birth satisfaction, increasing a mother's satisfaction with her partner, increasing breastfeeding exclusivity and duration, and initiation, and on and on and on and on, diminishing pain perception, diminishing the length of labor. So doulas are a really wise proposition for sure. So hopefully your hospital does welcome them. But again, dig deeper and ask, you know, do doulas in your hospital impact these outcomes that I just listed? And maybe the tour guide, you know, might be able to direct you to a good group in your area, you know, a good reputable group of doulas. There are great websites related to doulas too. So a big question moms always have is how many people are allowed to be with her during the labor and birth? That is going to vary from hospital to hospital, so definitely ask that. And that number usually is going to change if a cesarean becomes necessary. Often it's one person or only two people that will be allowed to go in the operating room with her, just because of the nature of a surgery, a lot of people being involved, and often not a lot of space. So usually they are going to limit the number of people. So definitely ask that on the tour. And most hospitals have a recovery area where the mom would go after a cesarean. So the follow-up question to what happens during the cesarean is what happens after. How many people can be with me? Can my baby stay with me? And all that. We'll touch back on more of that in a few minutes. Okay, so during labor and birth, it's important to think about what's important to you, not what anyone else says. What's important to you? What's the most important to you? What can you live with? What can you not live with? So here's just a little laundry list of things to consider. In addition to some of these questions, you can ask about what the actual policy and procedure is around them, not just the rate of IV, for example, but do I really have to have one, or under what circumstances must I have one? Always understand, and any good tour guide is going to tell you that if you elect to have pain medication, including epidural, or if you need Pitocin, those things are going to require an IV and monitoring to keep things safe for the baby and the mother when those interventions are used. So what about intermittent monitoring? That's where you're on the monitor for usually about 15 minutes out of every hour, and then off the monitor for the rest of the time until the next check-in. That's great to help keep labor moving along. The more you move, the more labor keeps moving, and the baby keeps nestling down into the pelvis. So you can be walking the halls like our couple here. You can be in the shower. You can be, in the rocking chair, the birth ball, whatever. To get off monitor. Some hospitals have telemetry units, which are wireless units. Definitely ask if that's available with important follow-up questions like, how many do you have and do you use them? Because sometimes they have them and they're not used. So definitely follow up with those questions about not only what's allowed, but what's typical, what's common in their practice. So positions for pushing is a big, big topic that's important to a lot of moms today. Many moms don't want to give birth on their back. They want to be able to adopt whatever position feels right during pushing, so it's a good one to ask. And another huge one is about coaching, and we put coaching in quotes here because it's actually a word a lot of us at Lamaze cringe with because, coaching is very different than labor support. We want to let this mother find her own path and find what works for her. So the coaching we mean here is a negative thing about, yelling at them all, push, come on, and counting to 10 and, doing all this stuff that we know from the research is not effective and is usually very problematic to moms. So what do? What can you expect in your hospital? Are the nurses going to want to do that? And even if it is common in your hospital, a good Lamaze class is going to tell you how to get around that and how to have them not do it. But it's good to know the lay of the land. What's the rate of episiotomy is another question moms will ask often. The good news about episiotomy is this is the one intervention that is falling in popularity, thankfully, but it's still an important one to ask. I always encourage follow-up questions here with your own healthcare provider. Often they'll say, I only do it when it's absolutely necessary. But, to some doctors it might be necessary 90% of the time. Well, we want to know when and why, under what circumstances they would do it. Because if the rate is 90%, that is not an evidence-based practice, I can assure you with great confidence. Again, back to the protocols if a cesarean becomes necessary. I think it's important to keep the birth as birth-like as possible when it becomes a surgical birth. A lot of moms report that. If you don't know the baby's gender, ask them not to tell you. Ask them to lower the drape so you can see the baby right as they come out maybe and say, see for yourselves, it's a boy, it's a girl. Can the dad or the partner go right over to the baby to see the baby immediately after the baby's born? Can they get the baby back to the mom as quickly as possible? There are some very, kinder, gentler cesareans going on in some parts of the world, some parts of the U.S., not most, but you can look at some of that online and see if that's being done in your hospital. Cord clamping is a hot issue right now.
Can you just explain what an episiotomy is?
Sure. I'm sorry?
Can you explain what an episiotomy is?
Oh, I'm sorry, sure. An episiotomy is, do I have to, Casey? An episiotomy is actually an incision or a cut to the mom's perineum. The perineum is the bit of tissue between the vaginal and rectal openings, and the perineum gets cut with sterile scissors or scalpel to enlarge the vaginal outlet to help the baby to be born. So I was born in the 1970s, and I can tell you that pretty much all mamas were getting episiotomies then, because there was a common belief then that it would greatly diminish the length of labor, which we know is not true. It's on average about 10 minutes that it would diminish the length of labor. And the other belief back then was that it was better to heal from a clean cut, like an episiotomy, versus a jagged tear that could potentially happen when the baby's on its way out. And we know that both of those things are just not proven to be true in the literature. That is, natural tears heal usually much better than an episiotomy. And once the baby passes over that episiotomy, it's very common for that episiotomy then to extend and rip a little bit as the baby comes out. So, like I said, the good news is, you know, if you ask most practitioners, they're doing, you know, less than 5 of them a year, and those 5 a year might be when the baby is in true fetal distress and we need to get that baby out quickly. So that extra 10 minutes on average of labor would really matter for that baby. Episiotomies are also used when they need to use instruments like vacuum or forceps to get those instruments in and on the baby's head. An episiotomy would be necessary for that. So thank you, Casey. I'm sorry I didn't clarify that. Okay, so cord clamping is a common one people are asking about. There's so much research that says even delaying clamping and cutting of the umbilical cord by 3 minutes really diminishes the baby's chance of having anemia, which is low iron, later in their life. Mostly they're looking at juvenile anemia or infantile anemia, so they're, you know, young children we're talking about here. But cord clamping, a lot of parents want to delay that now. And, you know, that is a evidence-based practice to delay cord clamping. The reality is a lot of doctors and some midwives don't delay it. They just clamp and cut immediately. So if that's important to you, it's a good thing to ask. Sometimes people on the tour want to know, oh, can my husband cut the cord? Sure. You know, most hospitals, the answer is going to be absolutely yes, unless there's something going on, you know, medically with the mom or baby. That is commonly offered everywhere for the support person to cut the cord if they want to. I was at a birth once where the husband didn't want to cut it, and the mom, who had just given birth, said, can I cut it? And she was on her side, you know, having pushed the baby out on her side, and she kind of did a little crunch and sat up and cut her own cord, and it was amazing. So most hospitals are really happy to let parents do that if they want to do that. So definitely asking about what happens for the baby right after birth, and we could do a whole webinar, maybe we should, on skin-to-skin contact and why that is so important for mothers. It's so important for babies from a kind of a biologic and physiologic standpoint. It's great for breastfeeding. It's great to help the mom get that placenta out and diminish bleeding. It's great for so many reasons, and most hospitals are catching on to that fact. So definitely ask what goes on. Will they wipe the baby off and put the baby right on you for the baby to rest and recover and transition skin to skin, which we know from the medical evidence is absolutely the best thing for moms and babies. I'm just checking my notes here to make sure I didn't skip anything in this section. Oh yeah, pictures and videotaping is something people ask me about a lot on tours. Find out if that's important to you. Find out what your hospital's policy is about photography and video. Usually they're going to say you have to ask the doctor or the midwife that's attending the birth. And the one I can tell you probably universally that's true is that no hospital wants you videotaping or shooting pictures in common areas like hallways or lounges where other patients or families or visitors might be in your pictures, and they don't want to be in your pictures sometimes. Okay. Yeah, and a good question here to ask, too, about skin-to-skin and what happens for the baby afterward is, does this change day to night? And that, you know, at night, if staffing is lower, do I still get a lot of skin-to-skin time with the baby or breastfeeding help or whatever? So we're going to do another, oh, actually, sorry, we're going to finish talking about postpartum before we do a poll, sorry. I mentioned skin-to-skin already. Rooming in is where the baby stays in your room, or your postpartum room, in a little bassinet. Usually, sometimes there's co-bedding. That's not particularly common here in the U.S. But definitely ask about rooming in, or must your baby to go to the nursery. That's a very common one. Our practice is different if you have a cesarean, like I said. And what's the breastfeeding support? This is one definitely to spend some time on. Again, remember, Those of us that are tour guides, part of our role is to present the hospital in its best light. And if they say all of our staff are trained in breastfeeding, I would ask how recently were they trained? Is there ongoing training? Are international board certified lactation consultants available? I am very concerned if a hospital doesn't have at least one IBCLC. I think they should have a lot more than that, but I know budgets are tricky sometimes. So definitely ask really careful questions about breastfeeding support. Okay, so now we're going to do our poll. What topics are you or have you been most interested in learning about in your Lamaze class? So please check all that apply, and then Casey's going to let us know. So let me know, Casey, when we've got something.
Open now. We'll just give people a second to vote.
Sure.
Okay. So about 69% of people are interested in finding more about routine interventions. 69 are interested in how to lower their chances of a cesarean. 47 are interested in how to avoid damage or injury to the perinatum. And 59% of people are interested in breastfeeding and postpartum baby care.
Great. Okay, good. Good, thank you. Okay, so we're going to use this tour ideally to gather that real sense of what the care options are for you and what you need to talk to your own doctor or midwife about. If you're taking a Lamaze class, even if you're not, go online and look at lamaze.org and look at those 6 healthy birth practices that we talk about. How well do the practices in your hospital line up with those 6 healthy birth practices, which are all evidence-based? The more simple we keep this first, the more likely it is to work well, right? Let your body do what it needs to do, not put a lot of interventions in the way, and things are much more likely to go easily for you. So I said this already, but it definitely bears repeating. Taking a tour in early pregnancy can give you a chance to digest this information and switch gears. If you're seeing that your preferences are not in sync with hospital protocols or even your own provider. So what do you do if you have concerns? Well, always I think the best place to start is talking to your own doctor or midwife about what your concerns are. And going back to my own story, that's exactly what I did. I said I didn't like this, that, and the other, and my midwife was able to say, but I'm with you the whole time, and I'm not going to let this or that happen. Here's our workaround on this policy or that policy. I didn't want my baby to go to the nursery, and she was able to arrange that that didn't happen. So definitely ask, even if it's not offered on the tour, ask for other alternatives. Most hospitals have a provision for parents that don't want to separate from their baby. I know we have that non-separation provision in our policy. Some hospitals don't separate you at all, which is wonderful. But if you're in a place that typically does put babies in the nursery for some or much of the time, definitely say, if there's nothing wrong with my baby or me, everything is great and fabulous, can't the baby stay with me? And the answer should be yes. And if not, that may warrant you to explore other options in this example. So maybe you can solve your issues by finding another healthcare provider within that same hospital. Maybe it's a family doctor or a midwife if you're with an OB. Maybe it's another OB. Sometimes, it might not work out where you are. You might have to work really, really hard to get the kind of birth you want in this particular hospital, and you might say, I don't want to fight that hard. I don't want to work that hard. Maybe I want to go to another hospital. So that's your choice. Maybe you say, you know what, I don't want to be in a hospital. I want to have a birth center birth or a home birth. It's all about having that safe and healthy birth and getting the care that's proven by research to be best for you and your baby. There's really no shame or harm in asking around to see what else is available out there. I like to tell my patients that we work for you. We are here to support you, and I had my babies. I made my own choices. We're here to support your choices. And the other thing is you're probably not inviting us to Thanksgiving dinner. I'm all set. I cook, by the way, in case you wanted to invite me. But, it is a business relationship, even as much as we want to make it a personal relationship. And don't worry about hurting someone's feelings and changing practices. This is way too important of a decision for you in your grand scheme of life. It's much more important to get the birth that you want and that you need and the appropriate care for you and your baby than to worry about hurting your doctor's feelings if you switch. Okay, so we have our another poll here, our fun poll. When is it too late to switch providers or hospitals? What do you think? I think I might have alluded to it there. So we're going to open the poll, and Casey will let us know. What are they saying, Casey?
Okay. About 4% of people say after the first trimester, 8% say after the second trimester, 26% say upon going into labor, 6% after you've passed your due date, and 56% when the baby is out.
Good for you. Yeah, we love that. Number 2, when the baby is out. That's when it's too late. I have had people change providers at 38 weeks, 39 weeks. It is absolutely your right to do that. Yes, it might be harder and stickier with insurance, but you know, we really want you to think about that. So that's part of pushing for better care. So how do you push for better care in general? Hopefully you'll put today's tips into play. Definitely go online and explore the Push for Your Baby campaign resources, and I'm going to give you that link in a second. And find a great Lamaze class. Take a great Lamaze class. Not all classes are created equally, so look for a Lamaze certified childbirth educator for sure, and ask what goes on in those classes to make sure that it's right for you. So today we learned what issues to explore during the hospital tour and how to tell what's typical versus what's available. So I really hope that everybody will go on and push for better care for you and your baby by putting these tips into play and learning more about what we've talked about today. And there's great opportunity to do that. Lamaze has wonderful resources for you on the website. I love the free weekly emails, 40-week emails. We're going to give you that link in a second. We have the official Lamaze guide and a great blog called Giving Birth with Confidence, and online finding a Lamaze class, all on lamaze.org. And Casey, I think we have some time for questions if any have come in.
Sure. So I just want to remind everyone to go ahead and enter any questions you have for Allison into that question box on the lower right-hand portion of your screen, and we'll try to get those answered for you in the time we have left. Allison, we've had a couple come in. I'm going to go ahead and ask them on behalf of the audience.
Thanks.
Why does a birth plan bother nurses and doctors, and how do I communicate my preferences without irritating them?
Why does it bother them? Well, I have to say I'm not a nurse myself, but from what I understand from friends who are, it's almost this folklorish tale that people start believing that if you ask for all this stuff, you're just going to end up with a cesarean. And you know what? There are some old school people that say, you know what? I'm the expert, I'm the nurse, I'm the doctor, I'm the midwife. Just come in and let us take care of you. So unfortunately, sometimes that does prevail in care in places, you know, here in the States and around the world. You know, they want you to come in and be a good patient sometimes, which is not what you need to be. You need to advocate for yourself and for your baby. So you know, more than that, I can't say really, but I have to say the bulk of midwives and doctors and nurses that I talk to kind of hate birth plans. So that's why I get picky with the words and say, just say, here's a list of preferences. In an ideal world, this is what I would love to have happen, and just be very low-key about it. So that's to the next question of how do you communicate these preferences without annoying people. I think just think about basic manners and etiquette. Try not to bombard people when you're coming in. They have a lot to do when they're admitting you. You know, I had to get involved in a situation not that long ago between a patient and a nurse, and the father was obsessed with the baby not being separated after the birth, which he has every right to be. But before the mom even was admitted, before the nurse said, what's your name, what's your date of birth, and all that good stuff, the dad was hammering away at the nurse, and the nurse kind of snapped at him and said, we don't even know if she's getting admitted yet, which, by the way, she wasn't. She came back and had her baby 3 weeks later. So definitely just respect that there's a lot that needs to go on, you know, when you're coming in initially. And there is usually, unless the birth is super fast, usually going to be plenty of time to discuss this stuff. So try to roll with, you know, with what's going on the intake first, and then say, okay, is it a good time to talk for a minute, nurse, about what we want to talk about here? So just basic manners, basic etiquette. Watch your own body language. Watch your word choices. You know, again, knowing and say, I know labor is unpredictable, but, you know, can you help me with this? And try to enlist them as your ally, and let them know why it's important to you. Yeah. Anything else come through?
Yes. How far can you go in avoiding procedures that are called necessary? Can you deny every procedure in the hospital?
Technically, yes, you can. It just depends on how much you want to endure as you do that. There are cases of women, a common one is, doctor or midwife wants to induce me next week. I don't want to be induced. I want to let labor start on its own. How far can you take that? Well, in any of these cases, coming to the table, so to speak, with alternatives, I think is important. Instead of just saying, no, 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 I won't, I don't want, or whatever, saying, tell me why, tell me what it is that you want to do. Tell me why it's important and why it might benefit me and my baby. Tell me what the downside is, what the risks are, right, and what the alternatives are. So, I had a mom not that long ago who was really, the doctor really wanted to induce her, and she said, what if I come in every day for a sonogram or a biophysical profile or whatever he wanted to do for her? Will that make you comfortable? And he said, fine, that'll make me comfortable. So once you're in the hospital, it's still important to advocate and again, to ask those simple questions. What is it? Why might it be good? Why might it not be good? And what are my alternatives? And, if it's that somebody wants to start Pitocin to speed your labor up, you might be perfectly comfortable with letting labor go as it's going. And, so say that and say, you know what, can you check me again in a couple hours? I want to get in the shower. I want to walk. I want to, do whatever. That's going to make you look a lot more reasonable than if you just say no. But the bottom line is it's your body and you have a right to do whatever you want with it. But, if they're recommending a cesarean for a really good medical reason, like, true fetal distress, which is tricky because as a parent you don't know how to read that fetal monitor, that's a harder one to negotiate out of. But asking for a second opinion, and obviously, if it's in the best interest of your baby, I hope you don't opt out of it. But asking for a second opinion is a good thing to do. But knowing that sometimes, they'll bring in somebody that's going to back them up. So it's a hard one. It's definitely a hard one. But going to class and really educating yourself with good information is going to give you the background to know when, kind of how far to take it, I think.
Okay. If I'm giving birth at a teaching hospital, am I allowed to tell the doctor that I do not want residents or medical students in the room?
Yes, you are. Yes, you are. And like I said, regardless of your insurance status, you're insured, you're uninsured, you're Medicaid, you're whatever, it doesn't matter. You have a right not to be a teaching case if you don't want to be. I will tell you that in a lot of hospitals that have residency programs, though, a lot of doctors work out that agreement that the residents are going to care for you until they come in. So that's going to be sometimes where you have to say, okay, this, excuse me, this doctor is going to work for me, or this scenario does not work for me. But once you're here in the hospital, you can say, you know what, I don't want students and observers, watching or providing my care. You have a right to say that.
You mentioned at one point in the presentation a gentler C-section. Can you elaborate on what that is?
I'm probably not the best person to elaborate on that because it's unfortunately not done here in my hospital, and as a doula I haven't seen it done. But there are many places around the world where they're taking the baby out through the incision and drying them and putting them right on the mom to do immediate skin-to-skin, just like a vaginal birth, not doing lots of suctioning on these babies, lowering most of the lights in the room except for the surgical overhead light, speaking in with soft voices, having music, just really, really kind of dialing back the surgery and making it a more pleasant and birth-like experience for the mom. Leaving the cord long so that the dad can cut it. They'd have to cut it to detach the mother and the baby when the baby comes through the incision, but leaving it long so the dad can or partner can cut it again, closer to the clamp like they like to do. But there is information online about that. If you Google family-friendly cesarean, you would find much more about that.
Okay, I think we have time for one more question. If someone's not happy with their support they're getting during their labor, how do they tactfully switch nurses in labor? She's not sure if she'd feel comfortable saying to the nurse who's actually taking care of her, but what if there isn't anyone else available? How do you go about expressing that concern?
There really should be someone else available. I'm sorry, the question is about not wanting to say that directly to the nurse that's caring for her?
Right.
Yeah, I hear you. I'm the same person. I wouldn't want to do that either. There always is a charge nurse, and during the daytimes there's, usually a nurse manager around. So I would say, dad or partner, to go out to the nurse's station and just say, hey, who's the charge nurse today, or could I, I'd like to talk to somebody, I have a question, and just be low-key about it, and then get that person aside and say, look, if you have a problem, if the nurse is, whatever, she's being rude or unsupportive or, grumpy or whatever, definitely you should let the manager know that, because we want to know that, in hospitals to provide better care, certainly. But if it's just a philosophy thing, or you're not clicking, that's an easy thing to say. Look, this is the kind of birth we're trying to have. I don't know if nurse so-and-so is really on board with that, and that's okay. Really, we would appreciate it if we could get somebody else. Nothing against her. I'm sure she's a great nurse, but it's just not working for us. This relationship is not working. And that does happen, and it's okay. Again, you're not inviting these people to Thanksgiving dinner. It's really okay to go out there and just privately, don't make a big scene, but, privately go out there and talk to whoever's in the leadership role and get that nurse changed. Oh, and I'm just remembering one more thing about the family-friendly cesarean, a gentler cesarean. In surgeries, often the mom's hands are restrained, tied down, just because they don't want to contaminate the sterile field. So in these births, they wouldn't have the mom's hands restricted. The mom would be able to hold her baby, skin to skin with her own hands, as opposed to being tied down, so to speak.
Okay, it's about time, so I'm going to end questions there, and I do want to refer everyone on the call to the lamaze.org website. There is a place where you can submit questions to a childbirth educator, just like Allison. Her name is Hensi, and she can answer these questions for you as well. And also, feel free to send any follow-up questions to education@lamaze.org, and we can send those to Allison to get those answered for you. When you exit the webinar, you'll just be brought into a brief survey. We really do appreciate your feedback, and we'll be sending out the information from this last slide to everyone to be able to access additional resources and a list of questions to ask your care provider. So thank you to Allison today, and I just want to thank everyone for attending.
Thanks, Casey, for your help.